Good morning. The pattern hair loss. This tutorial is based on the book Practical Guide to Hair Transplant, Chapter 19. The purpose of making this tutorial is for the better understanding of the chapter written. This is mainly for the novice hair transplant surgeon and intermediate level. If anyone is interested in going in the detail of individual things, he can refer to the other related chapters to know more detail about it. So I am going to cover the introduction, characteristic pattern of hair loss, epidemiology, pathogenesis of pattern hair loss, clinical manifestations, investigation, classification, and what are the uncommon patterns of alopecia in men, finally treatment, and then we will revise the entire chapter what we have heard. The pattern hair loss is one of the most common hair loss both in male and female. 90% of male over and above the age of 40 suffer some kind of hair loss or thinning. Clinically, there is a progressive thinning of hair in a pattern which is expressed differently in male and females. Like male, there is a anisotrichosis, I'll explain. Thinning is there, baldness is there, receding of anti-hairline, while in female, hairline is maintained but thinning over the vault area. The male pattern hair loss or androgenetic alopecia is genetically determined progressive process in which there is conversion of terminal hair to vellus hair. As age advances after puberty, the process increases in incidence and severity. It starts from thinning of hair, usually in the frontal region. As it progresses, there is a receding of entry hairline and deepening of frontotemporal area. You can see here they are the thinned out or the vellus hair. This is frontotemporal region which is receding, and similarly the hairline is also receding in the frontal area. There is also, you can notice the thinning in the temporal area. So this is a basically characteristic feature of fronto male pattern hair loss. They can be associated thinning or hair loss in vertex area or other part. This reduces self-esteem, loss of confidence, and anxiety in affected man or the young individual. So the characteristic features of pattern hair loss is there is a diversity of thickness of hair called an anisotrichosis, means there is a variable thickness of hair. Some are thick, some are thin, and some are very small. That is the variable thickness which you can even see on dermoscopy, even naked eye you can see, and also you can use mobile camera, take the pic and you can zoom it. You will clearly notice that there is a variable thickness of hair, that is the anisotrichosis. There is a reduction of hair per follicular unit. I'll show you how it is. The pattern of thinning and or loss differs in male and female. Of course, there can be some time overlap. Some female may also show the pattern hair loss like male, means the receding in frontotemporal area, but most of the females maintain the anti-hairline. The anagen phase of hair cycle shortens. So making hair shorter and finer means the anagen phase is what? It is the growing phase in which there is a multiplication of the cells in the dermal papillae. There is a layering of the cells are added at the bottom of the hair, and the hair pushes itself outside the follicle, so increasing in the length. But because of lack of division of the cells or apoptosis, this division of cell is reduced, so hair growth is reduced and hair becomes shorter and finer. The telogen phase may be same or longer, leading to more hair shedding and increase in the number of empty follicles on the scalp. Hair follicle closer to erector pili muscles are resistant to miniaturization as compared to the hair who are further away. Means in a multifollicular unit where the rectopili is attached, the side, so those are resistant initially. Distal to that attachment, they goes first in miniaturization. Later on, the rectopili get detached from the rest of the follicle and they also goes in miniaturization. Pattern hair loss in male usually starts anteriorly, first involving the frontotemporal region, followed by receding of anti-hairline, which I have shown you in the picture. Female pattern hair loss appear as a diffuse pattern in the frontal, mid-scalp, and the crown, with or without loss of fringe. So this is the typical male pattern in which there is a receding in the frontal area, there is a receding, more receding in the frontotemporal area. So this becomes deeper as compared to this, but there can be loss here also, and you can see that's how in the lateral profile it looks. These are the picture which I have shown you previously. Thinning is there, and there can be an isotrichosis and involving the miniaturization over the most of the scalp, means the frontal area, then mid scalp area, even the vault is also having the miniaturization. So how the process of miniaturization, as I explained, this is the rectopelli multifollicular unit is there when because of the androgen genetically susceptible hair follicle undergoes miniaturization, and first the hair follicle which is distal to the attachment of the erectopili undergoes miniaturization, means thinning. They become shorter and the hair becomes thinner. But as it progresses, the erectopili lose its attachment to those hair follicles which are getting miniaturized. Or we can say when the erectopili get detached from there is a further progression of the miniaturization. It further gets miniaturized, thinning of the hair continues, shortening of the hair follicle, and finally even that single hair follicle which had the attachment of erector get detached also, and that last remaining hair follicle out of that multifollicular unit also underget miniaturized, becomes smaller, and gradually it disappear from the surface, giving the appearance of a bald scalp. That's how the process of miniaturization continues. The pathogenesis, the exact pathogenesis is still incompletely understood, as there is a variation in the pattern as well as differences in response to the current modalities of treatment. Means we do prescribe minoxidil finasteride to all the patient of androgenetic alopecia male, but they do not respond in the same way. So that creates a doubt that there can be other factors which are responsible for causing this hair loss or miniaturization. But it is clear that genetic predisposition and the role of androgenic pattern hair loss is proved. So, pattern hair loss, genetic factors are proved, androgens are proved, environmental factor like lifestyle, stress, nutrition, toxins, pesticides, smoking, tobacco, they have got the weak evidences, but do they affect to me in my clinical experience? I have seen that environment has also a great role, but there is one study which has been very popular, Hankawa study done in 1992, in which 151 identical twins were studied, and they showed the environmental effect was only 8% in them. The epidemiology, Hamilton estimated that 30 to 50% of the men developed male pattern elbows by the age of 50 years. Many Western studies have shown that there are racial as well as age related differences in the incidence and the pattern of hair loss in male pattern alopecia. The pathogenesis. The James Hamilton was the first who found the role of testosterone in male pattern hair loss. He noticed that eunuchs and the men who undergone castration before puberty do not develop the male pattern baldness. Male pattern baldness is because of sensitivity to the androgen in a genetically susceptible individual. Means you need both. You need a lock and you need a key. Then the lock, then there will be miniaturization process will start. Means its genetical susceptibility and the androgens. Testosterone is mainly responsible. Testosterone gets converted into a very potent metabolite, that is dihydrotestosterone, by an enzyme called as 5-alpha reductase. And 5-alpha reductase has been found in the various part of the body, and they are two types of alpha reductase. One is type 1, another is type 2. Alpha 1 is found in the pilosebaceous and sebaceous gland, while alpha 2 reductase is found in prostate, dermal papillae, and outer root sheath of hair follicle. It's very important that type 2 is found in dermal papilla and outer root sheath of hair follicle and also in the prostate. DST is much more potent and it has got 5 times more affinity for androgen receptor rather than the testosterone. That is the reason we call dihydrotestosterone is a more potent androgen as compared to the testosterone. The evidence in favor of androgen causing male pattern hair loss is the peoples who has genetic deficiency of type 2 alpha reductase do not show male pattern hair loss. As I said, the conversion of testosterone to dihydrotestosterone is initiated by enzyme type 2 alpha reductase in dermal papillae and outer root sheath of the hair follicle. So, in the individual in which the genetic deficiency of type 2 is there, they do not show male pattern baldness. Similarly, alpha reductase inhibitors like Finasteride and Dutasteride, when they have been given to the patient, they showed the beneficial effect to treat the male pattern hair loss. So, these are the two strong evidences which supports that male pattern hair loss or AGA, there is a role of androgen. Then we come to the next factor, that is the genetic factor. The O'Brien did the study and he found that male pattern hair loss is an autosomal dominant. Male pattern hair loss is also polygenic. More than one gene is responsible, but among all, the androgen receptor AR gene is the most important. The evidence support that AR gene location is on the X chromosome, explaining the maternal component or inheritance. Means the AR gene is located on the X chromosome, and X chromosome become that it comes from a female. So there is a component, maternal component, means it comes from the mother side, but it doesn't make any difference as far as the clinical appearance is concerned, because the genes may come from mother to a male child and male child becomes the father of another child. So he got basically directly from the father, but father got from the mother. So that's how we say it has got an X chromosome. The other evidence proves that there is a higher expression of AR gene in balding scalp as compared to non-balding scalp. This is also important thing you should know, that AR gene concentration or expression of AR gene is much more in the balding scalp as compared to non-balding, because the AR gene receives that testosterone potent metabolite, means dihydrotestosterone. It is found that men with Kenny's disease do not show male pattern hair loss because there is a genetic defects in AR gene. Means Kenny's disease is a disease in which AR gene is absent, and such person do not show the male pattern hair loss. The other factors affecting hair growth is the hair growth is also affected by the level of insulin growth factor IGF-1, basic fibroblast growth factor FGF, and vascular endothelial growth factor. These are anagen maintaining factors and they promote the hair growth. Means fibroblast growth factor, insulin, and vascular endothelial growth factors are growth promoting factors, while Other factors: growth is adversely affected by premature apoptosis of dermal papillae cell, which may take place through the production and release of cytokinin such as transforming growth factor beta 1, interleukin 1 alpha, and the tumor necrosis factor. So these causes the inhibition of the growth. So there are the two type of factors are there. One is the growth promoting, another are the who causes the inhibition of the hair growth, and out of that the most important is transforming growth factor beta 1, interleukin 1 alpha, and tumor necrosis factor, which has got the negative influence. Now we come to the clinical manifestation. The complaints of either increasing hair shedding or loss of volume. The patient often shows increased hair shedding, especially while combing. There is a decrease in anagen phase duration and increase in telogen phase, means shedding phase increases and the growth phase decreases. And the most common complaint when the patient comes to you, that he tells my volume has reduced, my scalp has got thinned out, or also he says that there is a constant increase of hair loss which I am noticing for last few months. Reduction in anagen phase reduces the length of hair shaft, which I showed in that picture. Over the time, the length of hair fiber is reduced to the extent that hair is not long enough to reach the scalp surface and the follicle looks empty, which I showed in the previous picture. Ninogen phase becomes more longer, or there is a delay in the replacement of telogen hair, so area finally becomes bald. Commonly, there is a receding of anti-hairline and deepening of frontotemporal area. Patient may also present with diffuse hair loss and or thinning and loss of hair only in the vertex region even. Some patient may show only thinning or baldness or hair loss in only vertex. Presentation may vary, but the presence of miniaturized hair is the hallmark of AGA, result which you see by heterogeneous population of hair shaft thickness. Means whatever the presentation, he may present with receding, he may not show the receding, but he may show there is a thinning or baldness in only the vertex. So this is a clinical presentation, but when you examine closely or by dermoscopy, you see there is a variable thickness of hair. You can see hair shaft. That is a pathognomic sign of AGA. Norwood and Hamilton and a few others have developed classification of male pattern hair loss. Most commonly followed is Norwood. This is what you can see. There is a deepening of frontotemporal area. There is a thinning. You can say some hair looks adult hair, some hair looks thinned out. So this is the heterogeneous population, deepening, receding of anterior line. This is a classical example of AGA. Now it is what it was like this, and it receded to this. Though we come to the investigation, test and investigation, the most not a specific test, not much of the investigations are needed. Clinical examination and history itself tells you and makes the diagnosis. General CBC, hemoglobin, blood sugar, SGOT, GPT, creatinine, bleeding, and clotting time. Other tests are HIV, Australia antigen, and nowadays it has become RT-PCR for COVID, and some also advocated for ECG and HbA1c. Specific test, if indicated, then the hormonal assay, then thyroid profile, serum ferritin. If you think clinically, vitamin B12, vitamin D, and other specific tests is like hair pull test, hair wash test, skin biopsy, and trichoscopy. To me, trichoscopic is an should be a routine investigation. It should be in your office setup. Always you should examine the scalp by using the dermoscope or by trichoscopy. This is the dermoscope. As I explained, the classical picture is heterogeneous population, means thick hair, there can be the intermediate thinness of hair, and there can be very thin hair. So this is the heterogeneous population. This is the normal scalp dermoscopy picture. These are good thickness and multifollicular units are present, and that's how the picture is. This is the picture of AGA having the miniaturized hair. Variable thickness of hair means an isotrichosis. Then hair pull test, you can also do the hair pull test. Hair pull test initially in AGA is positive, means more than uh, 7 hairs out of 10 comes out when you do this test. So it's positive in initial phase, but once the hair loss gets stabilized, then the hair pull test will be negative. Another important thing is hair pull test is negative from in the occipital area of the AGA if but patient is having diffuse unpatterned hair loss, then that is called as DUPA commonly. In that case, there can be positive hair pull test in occipital area. The histopathology, this certainly decrease in terminal hair and anagen hair, increase vellus and telogen hair, increase in follicular stele means the presence of fibrous tract at the place of terminal hair, ending in superficially located miniaturized follicles, mild perifollicular lymphocyte infiltrates primarily around the hair follicle, concentric perifollicular fibrosis may be present, and very important thing is that sebaceous glands remains intact. So, how to make the diagnosis? Take the history of the patient, means he will tell you loss of volume, loss of density, thinning. Thinning is much more important than the hair loss. And on examination of hair and the scalp, and also do the dermoscopy, and if needed, you go for blood investigation as I explained, CBC, vitamin SA, ferritin, etc. And then you can correlate, means history, examination, and basic investigation. You can very well make the diagnosis. But sometimes it may not clear, then advise specific test like hair pull test and the biopsy, especially when you are suspecting the scarring alopecia. So the test result will finally make your diagnosis and then start the treatment. Whether it is medical treatment, it can be adjuvant, means off-label treatment like PRP and low light laser therapy, and if needed, there is a defined baldness and hair loss gets stabilized. Patient has taken the treatment, then they are the candidate after having the discussions, then they can undergo surgical treatment. The classification of pattern hair loss is there are many classifications. Most commonly followed is Norwood stage and its variation. Another is the Hamilton classification. Norwood stage has got stage 1 minimal recession along the anterior border of the hairline, means there is a minimal recession is there. But Norwood stage, the further recession progresses to the extent that the deepest point of the frontotemporal area, distance from this point to a line passing from external auditory meatus, distance is more than 2 centimeter. So they are further away from this line more than 2 centimeter, then it is grade 2. But if this distance is less than 2 centimeter means the deepest portion of frontotemporal angle and the external auditory meatus, then it is grade 3. But grade 3 vertex can also be there, in which there can be loss in the vertex area. So this is the vertex 3 classification. Then the Norwood stage 4. In this Norwood stage, the further deepening of frontotemporal area takes place and it becomes deeper to a line passing from external auditory meatus, and also there is a thinning and baldness in the crown area. So this becomes stage 4. If we can get confused, do not get confused. with vertex 3 in which the hair receding is there, but receding is not to the great extent and there is a minimal loss. But here the receding is deeper, so it becomes stage 4. Then the stage 5, further deepening of the space, and there is a very small narrow bands of hair in between the vertex and the frontal area. This becomes a stage 5, and in stage 6, this fringe between the crown and the midfrontal area disappears, and there is a total baldness at the top of the scalp. This is stage 6. If it further progresses, then it is called a NORWOOD stage 7, in which the further loss of hair takes place, progression of baldness, and the temporal and occipital fringe also drops down, making it the highest grade of baldness, that is the grade 7. Now let's talk about the variation grade second A, third, fourth, and fifth A. The variation of Norwood scale described as grade 2nd A, 3rd A, 4th A, and 5th A are the two characteristic major features are present. Minor may present, may not present, but two characteristic features means what are those? The recession involves the entire frontal border. As I said, there is seeding of hairline in frontal region as well as frontotemporal region, but routinely, there is more deepening of frontotemporal space and less receding of midfrontal area. But in this variation, one point is this panniculus, midfrontal panniculus, is not there, and there is a uniform regression or receding of the tail line, same in frontal and both side frontotemporal region. That is the one of the major factor. Second, there is no associated hair loss in the vertex area. These are the two major features. The minor variation is that there can be few hairs in the area of recession, which is a horseshoe shaped fringe of hair remaining on the sides and the back of the scalp. Means there can be few miniaturized hair may be present, but rest of the character remains the same. And what is that? Means the panniculus in the frontal mid-frontal area is not there, which usually is in the Norwood stage 1, 2, 3, 4, 5. So this is what the entire picture of is grade 1 to 7, then the vertex grade 3, and then these they are the four variation in which the panniculus mid frontal panniculus is not there and the receding is uniform in mid and both side frontotemporal area. Then we come to the another type of pattern hair loss like the diffuse unpatterned hair loss, which is very important, you must know, in which there is a thinning and hair loss in the occipital area also, and hair pull test in initial stage will also be positive in the occipital area. That is called as DUPA or diffuse unpatterned hair loss. This is the diffuse pattern hair loss in which uniform thinning or baldness you can notice, but the thinning or baldness is not there in the occipital region. That is called as diffuse pattern hair loss. Then male pattern baldness with persistent midfrontal forelock. Midfrontal forelock is present, but in the rest of the area you will see the baldness. Another variation is the senile, in which old age it is seen, decrease in density over the entire scalp. In some cases, thinning is seen from nape of the neck towards the safe donor area. This is known as reverse pattern alopecia, you can see also, or retrograde alopecia. The another variation is persistent anterior fringe is present and rest of the area is becoming bald. And so it is a persistent anterior fringe type of baldness. Then the treatments are, they are effective medical treatment for male AGA. If started in early phase of treatment, can effectively control ongoing hair loss and can prevent the progressive baldness. US FDA has proved two treatment, mainly the minoxidil and finasteride, minoxidil finasteride for the male and only minoxidil for the female. PRP and others are off-label treatment, food supplement, vitamins, and also the off-label treatment. They are not being advised by US FDA for AGA. The minoxidil is one of the drug which was used in 1970 as an oral medication for refractory hypertension. But when it was given to those patients, they noticed there was a growth of hair. So this is an incidental or accidental finding that minoxidil plays role in the hair growth. The topical solution of 2 to 5% is US FDA approved treatment of androgenetic alopecia for both men and women. The effects of minoxidil on the hair are premature entry into anagen from resting phase. Means anagen phase, the hair which were in telogen phase, they enters into the anagen phase. So Abol reported an increase in anagen-telogen ratio at 12 months of his use. It elongates the anagen and shortens the telogen. In another way, we can say the anagen phase is increased while the telogen phase is decreased. There is an overall increase in the follicle size and also the mean diameter of the hair is increased. There are histological and clinical evidence that it works. Minoxidil is more useful in maintaining and thickening hair rather than regrowing the new hair. So minoxidil has got more role in making your thin hair to thick, but it's not going to bring the new hair. The use of topical minoxidil in peri-operative period prevent the usual shedding that occurs 1 to 2 weeks after the transplantation and reduces the time for regrowth by 1 to 2 months. The minoxidil should be stopped 2 to 3 days before surgery to minimize skin irritation, which reduces theoretical risk of intraoperative bleeding. So the main role of minoxidil in preoperative is that it reduces the post-operative shedding of the hair and there is likely early regrowth of transplanted hair. Half-life of minoxidil is 22 hours and its peak effects comes after the 40 weeks. So it is very important for you to explain to the patient that once you start the minoxidil, the effects will come after 3 to 4 months. Otherwise, patient starts using it, just they watch for a few days. If the result doesn't come, then they stop using it. It should be applied 5% twice a day on the dry scalp for the man is recommended and for the female 2% twice a day or 5% foam once a day is recommended. Minoxidil side effects are although less, but hypertrichosis means unwanted hair growth over the face and the other parts of the body, which is more commonly seen in females even at the lower dose. Spillage of minoxidil solution over forehead and the face may induce hair growth. This is if this condition takes place, just stop it. Irritation can also be another problem. There can be scalp irritation and pruritus, means itching, worsening of seborrheic dermatitis. The contact dermatitis allergic reaction is mainly because of the propylene glycol, less commonly because of the minoxidil salt. Minoxidil contraindication. The use of minoxidil during pregnancy and breastfeeding is taken as a category C. So during pregnancy and the breastfeeding, the minoxidil should not be used or should not be prescribed. The dose in the male 5% solution twice a day. The solution is to be applied over the dry scalp. If the foam is used, then once a day can also be applied. Another tablet is Finasteride. Finasteride is a competitive inhibitor of type 2,5-alpha reductase. Taken orally, it reduces DST level in serum and in scalp up to 70%. There are two main isoenzymes we know, type 1 and type 2. Type 1 is found mainly in the liver and sebaceous and pilosebaceous gland. Type 2 found in dermal papillae, outer root sheath, and also the prostate. The effects of finasteride in the male, there is an increase of anagen to telogen ratio. Similar to the minoxidil, there is a more increase in the hair weight. The hair weight increases more than the hair count. Better at increasing the growth rate means the length and the thickness of the hair. Finasteride blocks the 5-alpha reductase type 1, cause 30% reduction of serum DST. Blockage of type 2 reduces 70%. So finasteride acts only on type 2, so 70% DST serum level is decreased. Now, what are the side effects or effects of the finasteride? Sperms, it has no significant effect on the sperm count, total sperm per ejaculate, sperm motility or sperm morphology on 1 milligram of finasteride every day has no effect. May occur at higher dose of 5 milligram but reversible once you stop the drug. So we can say it is safe for your sperm. If you are taking finasteride as a treatment of hair loss, because here the dose is 1 milligram per day. The prostate, finasteride is neither a promoter nor preventer of prostate cancer. Finasteride causes decrease in the prostatic volume, thereby the chances of detection of CA prostate is increased because prostate is smaller, and when you take the tuchus biopsy you get the more tissue which may be carcinogenic, and because of this it is said wrongly that it promotes the cancer, but there is no proof at all. The sexual adverse effect, the decreased libido, erectile dysfunction, ejaculatory disorder may find in patients. The incidence is less than 2% in the finasteride taking group and less than 1% in placebo group. These symptoms are reversible after stopping the drug. Effects on other part of the body, there can be gynecomastia and pain in the male breast, mastalgia, incidence is 0.4%, exfoliative dermatitis, perioral numbness, swollen salivary glands, depression, and side effects are reversible after stopping the drug. So that's important that side effects, whatever the patient is facing, they will stop once you stop the drug. So another very important thing is the post-finasteride syndrome, 5-alpha reductase inhibitor syndrome. It is also said like this also. So persistent sexual, physical and neurological adverse reactions in the patient who have taken the finasteride. Like understand somebody has taken the finasteride but he has stopped, but still his sexual side effects, neurological, physical will continue. That is the called as post-finasteride syndrome. The symptoms are depression, loss of libido, erectile dysfunction, suicidal tendency, anxiety, panic attacks, gynecomastia, muscle atrophy, penile shrinkage, cognitive impairment, insomnia, and severely dry skin and tinnitus. These are the symptoms, and any one of these may be present. Symptoms start showing after a few weeks of stopping the finasteride. This is a controversial issue, and yet no detailed scientific data is available. A causal relationship has not been established. Pre-existing mental health issues such as mood and anxiety disorder, bipolar or obsessive compulsive disorder seems to be the risk factors for development of uncommon syndrome, that is post-finasteride syndrome. Due caution should be taken with prescription of finasteride to these patients who are already emotionally labile. Another alpha reductase inhibitor is your Dutasteride. It inhibits both type 1 and type 2 5-alpha reductase isoenzyme. It is 100 times more potent in inhibiting the type 1 enzyme and 3 times more potent in inhibiting type 2 enzyme as compared to finasteride. We notice that finasteride only stops type 2, not the type 1, while dutasteride acts on both type 1 and type 2 alpha reductase. Dose of dutasteride is 0.5 milligram. This decreases scalp DST by 51 to 79% as compared to the finasteride, which reduces scalp DST only by 34 to 41%. So this is one important thing, that decrease in scalp DST is much more as compared to finasteride. The serum DST level is reduced by more than 90% as compared to finasteride, which causes only 70% reduction in the serum DST level. Dutasteride has got many side effects of they are long standing because of its long half-life, which is 5 weeks as compared to finasteride, which has got 6 to 8 hours half-life. So once you stop the finasteride, even then there will be blood level of dutasteride will be maintained in your blood at least for a month or so. So 0.5 milligram daily dose of dutasteride decreases the sperm count by 28% in 26 weeks, decreases the semen volume, decrease the sperm motility, but no significant change has been found in sperm morphology. This is again important thing. Not approved yet by US FDA for the treatment of AGA. Dutasteride is a potent teratogenic and its use is contraindicated in a woman of childbearing age. So these are the few difference between the dutasteride and finasteride. The topical ketoconazole is known for its antifungal property, commonly used to treat the dandruff, which is basically Pityriasis capitis. It has anti-inflammatory properties and anti-DST action also. One study shows that 2% ketoconazole with minoxidil shows better growth as compared to without ketoconazole. Another study says ketoconazole used for finasteride may lead to complete reduction of DST. AGA with seborrheic dermatitis are benefited by ketoconazole. So this is that few examples of the treatment: male pattern hair loss, diffuse, and after 5 months of our treatment of minoxidil, finasteride, food supplement, and etc. This is another case who improved just by the medicine. This is another case which improved the medicine. Other OTC products are saw-palmetto, biotin, nioxin, porcine, trichomin shampoo, camouflage, fix, hair pieces, vitamins, food supplement, and PRP. Surgical management includes first, commonly called as FUT. Second is follicular unit excision technique, that is the FUE, and body hair harvesting technique. What is the purpose of doing the hair transplant? As I said, patient entry hairline get receded and the composition of the face means the face aesthetic 3 units means upper, middle and lower get disturbed because of the receding of this anti-hairline. So there is a need to put it back to maintain the same proportion, and that's what the role of hair transplant surgery is, and that's why it has been done in the patient. This is a receding of the hairline I've shown you before, and after transplant he looks quite good. Thank you. The another one thing is there is a let's understand what happens in AGA. There is a receding, deepening of frontotemporal receding. So when you need to put it back in the same proportion. That's what has been done in this case. This is another case. So let's revise the entire chapter of pattern baldness. The progressive miniaturization of terminal hair is the hallmark of hair loss. Miniaturization is a process in which large pigmented terminal hair follicles are converted into colorless vellus hair because of the shortening phase of anagen. Pattern hair loss affects both male and female, although the clinical appearance may be different, but common thing is the progressive thinning of hair. Male pattern hair loss increases in frequency and incidence as the age advances after the puberty. Male pattern hair loss is characterized by thinning of hair in frontal, frontotemporal, and vertex area of the scalp with variable loss of marginal, parietal, and occipital hair. The diagnosis is made clinically based on history of hair thinning, loss of hair, local examination, and few simple tests. Anisotrichosis is finding on the dermoscopy. Two main causative factors responsible are genetic predisposition and derivatives of testosterone, that is the dihydrotestosterone. This is an autosomal dominant and polygenic. The gene X chromosome is linked, indicating the maternal component. Testosterone is converted by an enzyme 5-alpha reductase into a more potent metabolite dihydrotestosterone, which is responsible for male pattern hair loss. There are two types of isoenzyme, type 1 and type 2. Type 1 is found in sebaceous pilosebaceous glands, while type 2 is found in prostate and dermal papilla and outer root sheath of hair follicle. Finasteride and minoxidil are US FDA approved treatment for male pattern hair loss. Medical treatment is effective if started in early phase of hair loss. There are few side effects of finasteride, but the incidence is very low and they are reversible once you stop the finasteride. Medical treatment is not to treat the developed baldness. The treatment of baldness is the hair transplant of hair follicle. So my advice is, after listening this, it is advisable to read the chapter 19 from the book Practical Guide to Hair Transplantation. These tutorials are designed based on chapters written in the book. For details on examination and treatment, read the other related chapters in the book and listen other tutorials. For any query, you can write to me on this my email, that is anilgarg61@yahoo.com. I'll be happy to answer you. Best wishes. Thank you. Thank you very much.